Welcome to the training program of primary healthcare medical officers conducted by the Sri Lankan College of Internal Medicine in collaboration with the Ministry of Health. And today we are going to discuss about approaching to a patient with bronchial asthma or COPD at the primary healthcare setting. So I will start with a scenario where a 23-year-old female presents to the OPD in a central dispensary with a 3-day history of shortness of breath, cough, and wheeze. So she has two similar presentations to a GP in the last year, and in between she was doing well. She claims that she's always having runny nose in the mornings and she has eczema in the lower limbs. On examination, she has polyphonic wheeze all over the chest. How would you approach this patient at the primary healthcare setting? In summary, so this is a young girl who has come to the primary healthcare setting with no previous definitive diagnosis. She has a short respiratory illness with wheeze, cough, and shortness of breath with previous similar episodes. And in background, she has allergic rhinitis and eczema. So what differential diagnosis would you consider in this instance? Obviously, the bronchial asthma would be first in your list, given the history and the examination findings. But you might consider the possibility of recurrent chest infections, postnasal drip, or even gastroesophageal reflux disease. So how would you approach this patient? So history would be the far most important thing when it comes to a clinical diagnosis of bronchial asthma. So the patients will complain of wheeze, shortness of breath, chest tightness, and cough. And importantly, these symptoms occur variably over time and intensity. Patients will particularly complain that their symptoms are worse at night or particularly on waking up. And individual patients might have identified their triggers of the symptoms. One might say that the exercise worsens the symptoms, even laughter, cold air, dust, allergens, or viral infections. And if you take a history, obviously you will be able to pick up good days and bad days. And usually they have a background of atopy, eczema, or allergic rhinosinusitis. Yes. So in examination, so if you have to examine this patient in primary healthcare, most of the time you will find normal physical examination. But always listen and document these if they have, because this will be the one and only physical finding that you will find in this patient, and that is very important for future reference as well. And if possible, do a peak expiratory flow rate measurement in the OPD and document it. And the patients can have peak flow meters at home, and always encourage them to maintain a peak flow diary at home, so that looking at the peak flow diary, you can appreciate the reversibility and the variability. And you can check the peak flow variability after giving nebs with salbutamol in the OPD setup itself. So when you're assessing a patient with asthma, who is the diagnosed patient with asthma, always take account of the asthma control. Always ask about the symptoms, daytime symptoms, the nighttime symptoms, etc. And always look whether they have any other comorbidities, such as rhinitis, gastroesophageal reflux disease, obesity, obstructive sleep apnea, or depression. And then address the treatment issues, what medications they are on, what side effects they have experienced, and particularly the inhaler technique. So when it comes to the management in mild asthma, we used to prescribe salbutamol as needed, salbutamol inhalers as needed for patients with mild intermittent asthma. But the current guideline is such that short-acting beta agonists are no longer recommended, as it does not protect patients from severe exacerbations, and there is ample evidence that regular or frequent use of salbutamol inhalers alone increases the risk of exacerbations. Therefore, in all adults with asthma, we should prescribe a inhaled corticosteroid containing controller treatment as well. So again, I will emphasize the point that salbutamol inhalers alone should not be used as needed basis even in patients with mild intermittent asthma. So the important principles is that you have to understand the patients with mild asthma, even mild asthma, can have serious exacerbations. And low-dose inhaled corticosteroids in that context is very effective in preventing severe exacerbations, reducing symptoms, improving lung function, and preventing exercise-induced bronchoconstriction. And always in occupational asthma, early removal from exposure and early treatment increase the probability of recovery. So in asthma management, depending on the symptoms, we go for a stepwise management. So we start at a higher step and we step down depending on the response, or patients such as patients with mild intermittent symptoms, we start at a lower step and we step up. So the first step, the recommended treatment is to go for a low-dose inhaled corticosteroid 4-meteral combination taken as needed for symptom control. So the formoterol is a long-acting beta agonist, but what is good about formoterol is that it is very quick in action. So this can be used as a reliever therapy as well. But formoterol is not widely available. It's not freely available in the government sector. And even in private sector, some patients might find it difficult to afford. So in that case, we can prescribe them low-dose inhaled corticosteroid to be taken whenever short-acting beta agonist is taken. This recommendation is there because some patients might have very infrequent exacerbations. One might have an asthma exacerbation in every 2 months. So he might wonder, why should I take daily inhaled corticosteroid if I am to take salbutamol once in 2 to 3 months' time? So because of that, we recommend low-dose inhaled corticosteroid to be taken whenever salbutamol is taken in step 1. And step 2, again, the low-dose inhaled corticosteroid and formoterol combination can be taken as needed for symptom control. Otherwise, in our setting, we can consider using a low-dose inhaled corticosteroid with, as needed, short-acting beta agonist, something like salbutamol. And step 3, we can use, again, inhaled corticosteroid formoterol combination as maintenance and reliever therapy. If you don't have this inhaler, maintenance with a low-dose inhaled corticosteroid with a long-acting beta agonist, such as salmeterol, and as needed, salbutamol inhalers. And in step 4, we can increase the dose of inhaled corticosteroid and use medium-dose inhaled corticosteroid formoterol combination as reliever and maintenance therapy. In the absence of that, we can use maintenance medium-dose inhaled corticosteroid, a long-acting beta agonist such as salmeterol with as needed salbutamol inhalers. And if your patient's asthma is still not controlled, well, step up. And step 5 would be actually to get a specialist opinion, a specialist referral, and then to consider add-on treatment at a specialist level. Okay, and then we will briefly discuss managing an asthma exacerbation in the primary care. So as this patient, a patient can present with cough, shortness of breath, wheeze, and chest tightness. So you need to assess the patient. Is it asthma? And then assess the severity of exacerbation. Always consider the factors for asthma-related death, whether this patient had a previous ITU admission or an intubation. So if your patient has mild to moderate symptoms, he talks in full sentences, he's sitting up, he's not agitated, but he's tachypnic, and the pulse rate is 100 to 120. Saturation is 90 to 95%. Well, this patient could be managed at primary health care at the initial part. But if the patient has severe symptoms, he talks in words and he's hunched forward, he's agitated, he's very tachypnic, he's using all his accessory muscles, and the pulse rate is more than 120, and SATs have dropped less than 90%. and his peak expiratory flow rate is less than 50% predicted. Oh, your patient is having life-threatening asthma. He's drowsy. He has a silent chest and confused. Don't wait. This patient cannot be managed in the primary healthcare setting. Urgently transfer this patient to an acute healthcare facility after initial treatment. So what treatment can you offer in primary healthcare? Well, salbutamol, 4 to 10 puffs by a pressured metered dose inhaler with a spacer, which can be repeated every 20 minutes for 1 hour. And this is equally efficacious as giving salbutamol nebulizations. But as the nebulization is an aerosol generative procedure, and given the current pandemic, we recommend to use this pressured metered dose inhalers with a spacer device in contrast to using nebulizers. And we can start prednisolone 40 to 50 milligrams, and depending on the patient's saturation, we can give some oxygen targeting saturation 93% to 95%. And then we continue treatment with short-acting beta agonist as needed, and we assess the response. The patient's symptoms have improved, and he no longer needing short-acting beta agonist. And peak expiratory flow rate has improved, and it is more than 60 to 80% of personal best. And oxygen, without oxygen, he's maintaining saturations more than 94%. And the home situation is very satisfactory. The resources at home are adequate. Then you can arrange for a discharge from the primary healthcare setting itself. The reliever and the maintenance therapy need to be arranged. Always check the inhaler technique before discharge and advise on the adherence. The steroids that we have started, we can continue with usually for 5 to 7 days, and importantly, arrange a follow-up for this patient. And in the other hand, in primary healthcare, we see a lot of patients with recurrent presentations with uncontrolled asthma. So when your patient is repeatedly presenting to you with symptoms, always consider the following factors. Always take time, watch the patient using their inhaler, correct the errors, and always select the most appropriate device. Some patients might tolerate a dry powder inhaler much better than a metered dose inhaler, and look for barriers to adherence and address them. Then, if they have recurrent presentations, always think back, could this be something else? Could this be reflux? Could there be an element of heart failure? And then remove potential risk factors. Is he actively smoking? Is he on any beta blockers, NSAIDs? Or is there a persistent allergen exposure? And then look and manage comorbidities, rhinitis, gastroesophageal reflux, depression, anxiety. And once all these are addressed, then if they are still having symptoms, consider treatment step up. And if the asthma is still uncontrolled, that is a point where you should consider referring this patient to a specialist. So that brings to the end of asthma approach to an asthma patient, and we will discuss how to approach a chronic obstructive pulmonary disease patient in primary healthcare. I will again start with a scenario. This time, a 64-year-old male coming to the OPD in a central dispensary with a 3-day history of worsening shortness of breath, cough, wheeze with fever, and increased sputum production. He was having progressively worsening symptoms over the last 5 to 6 years, and he is a current smoker with 30 pack years. How would you approach this patient? Well, in primary healthcare, when to consider the diagnosis of COPD, you will see patients with long-standing dyspnea, chronic cough, increased sputum production, and recurrent lower respiratory tract infections. And they might have a history of exposure to risk factors, such as smoking. Then the confirmation of diagnosis, which may not be that feasible in the primary healthcare setting, but that is with the spirometry, which is the gold standard. So demonstrating the presence of a post-bronchodilator FEV1, FEC, Less than 0.7 confirms the presence of persistent airflow limitation. Well, when it comes to management, the non-pharmacological management and pharmacological management, they are equally important. So non-pharmacologically, smoking cessation is something very important that you should always ask about smoking in every clinic visit and always counsel the patient to quit smoking and offer necessary assistance for the smoking cessation. Promote physical activity. And if there are any pulmonary rehabilitation program, the patient can be referred. And please arrange vaccination, the influenza vaccine and the pneumococcal vaccine for your COPD patient. And when it comes to pharmacological management, the bronchodilators are the mainstay of management. So there are so many bronchodilators that you can consider. You have salbutamol, you have ipratropium, the short-acting muscarinic antagonist, and you have long-acting beta agonists, the salmeterol and formoterol, and long-acting muscarinic antagonists such as tiotropium. And even oral theophylline has a modest bronchodilator effect. And when it comes to the management of COPD, consider a combination of inhaled bronchodilator therapy, because these bronchodilators, they have different actions, and these actions can be synergistically used for a good bronchodilator effect. And without going on one bronchodilator maximum doses, having a combination therapy will minimize the side effect profile. And use these bronchodilators on a regular basis to prevent or reduce symptoms. Secondly, anti-inflammatory drugs. So inhaled corticosteroids in combination with these bronchodilators is shown to improve lung function and reduce exacerbation. The triple therapy, where a LABA, LAMA, and an ICS is considered superior to LABA, LAMA, or LABA monotherapy. And long-term oral glucocorticoids are not recommended. So when you consider starting an inhaled corticosteroid to your patient, having a history of recurrent hospital admissions with COPD exacerbations, and having a high eosinophil count in the blood, and history or concomitant asthma strongly support using an ICS. But if your patient has repeated pneumonia events, if the patient has a history of tuberculosis or having low blood eosinophil counts, that might make you think whether this is really necessary. So in such patients, you will have a higher threshold considering an ICS in the management. And the other medications, of course, roflumilast may not be available in the primary healthcare setting, but these patients, some patients may be on this medication, and it's important to know what it is and the effectiveness of that. So it's a phosphodiesterase 4 inhibitor used once daily, particularly in patients with severe COPD or chronic bronchitis who are treated with steroids. And it is shown to reduce exacerbations and improve lung function. Then for the long-term antibiotics, the azithromycin or erythromycin, long-term is shown to reduce exacerbations in high-risk patients. Well, home oxygen, again, you may not be able to arrange home oxygen at primary healthcare setting, but if you think your patient is stable but having significant arterial hypoxemia or having evidence of nocturnal hypoxemia, right heart failure, erythrocytosis, consider referring these patients to tertiary care center or a specialist center for consideration of long-term oxygen therapy because it has a prognostic benefit. But the absolute contraindication would be active current smoking. When it comes to the management of exacerbations in primary healthcare setting, the definition is acute worsening of symptoms needing additional therapy. So whenever a patient comes with an exacerbation, the symptoms are pretty non-specific. So think about other DDs. Could this be heart failure? Could this be pneumonia? And currently, could this be COVID? And look for common precipitants such as respiratory tract infections. Consider controlled oxygen therapy. So in COPD patients, their respiratory drive depends on the hypoxemia. So don't target higher saturations. Target your saturation between 88 to 92% and use relevant devices to give a controlled oxygen therapy. And then the short-acting beta agonist and short-acting muscarinic antagonist. Through a spacer device or through nebulizations, we can administer to the patient and initiate long-acting beta agonist as soon as possible before discharge. We can start them on a short course of corticosteroids, but not use them more than 5 to 7 days. And COPD exacerbations are likely infective, and antibiotics will shorten the hospital stay, recovery time, and reduce the treatment failure. So, always when you see a COPD exacerbation in the primary healthcare, look for these factors to see whether this patient needs urgent referral or urgent transfer to an acute healthcare facility. If the patient has severe symptoms, if the patient has features of acute respiratory failure, maybe having flaps, bound in pulse, or drowsy confused patient, or new onset of physical signs, cyanosis or peripheral edema, and failure to respond to initial medical treatment, and presence of serious comorbidities and insufficient home support, you will have to consider referring these patients to a specialist center or to a hospital. And end-stage COPD. Well, there are some patients who are at the terminal stage of COPD with a lot of symptoms. So your aim is to prevent and relieve suffering of these patients and to support the best possible quality of life for the patients and their families. We can use opiates such as oral morphine sulfate to reduce the subjective feeling of breathlessness. We can give oxygen for comfort. We can have fans blowing air onto the face to relieve the breathlessness. We can consider nutritional supplementation, as well as importantly, we can consider psychological support. So that brings to the end of the presentation. So this presentation summarized the basic approach to a patient with bronchial asthma or COPD in the primary healthcare setting. Thank you for listening.